One day I was riding my bike and I noticed a little pain. Had never been there before. Went straight to the doctor's office and he confirmed it was testicular cancer. Before you get sick, you just have insurance and don't think about it much. The experience we had with Blue Cross was fantastic. Finances are the last thing you want to be thinking about when you're sick. This whole thing's been going on for about 2 months, but I'm going to be dealing with it for a few years now until I get the all clear. Having the Blue Cross ID card in my wallet makes me feel secure, safe, and covered.
Welcome to Doctors in New Orleans, where you get to see firsthand how some of our local leading healthcare experts tackle health issues that are important to you. I'm your host, Maria Muro, and each week our goal is to help you take charge of your health. So now let's get started.
How far would you go to protect your child's health? If you're like most parents, that's a distance that can't be measured simply in miles. It's doing whatever it takes, no matter where that takes you. We know how far you'd go. We've been there. In fact, we go there every day so that you don't have to. A fully dedicated pediatric ER and the region's first and only on-site helicopter dedicated to kids, wherever they are. Children's Hospital New Orleans, caring for every child as our own.
Up next, Dr. Bernard, an ER physician at Touro Infirmary, recommends the FAST test as an easy way to remember the most common signs of stroke. He explains more.
My name is Dr. Matthew Bernard. I'm one of the emergency doctors and also the medical director of Touro Emergency Department. Thank you for having me. And today we're going to talk about stroke a little bit. Simply put, a stroke is when a piece of the brain begins to die from not getting enough oxygen. The main two types of stroke that we see are a bleeding stroke or a stroke because of a blood clot. And so a blood vessel can burst open through a weak spot, like an aneurysm, sometimes due to elevated blood pressure. And also you can have a blockage in our blood vessels, and that can cause a stroke as well. That's a much more common type of stroke. About 75% of strokes are the blockage type. A stroke is when a piece of the brain is dying, so it depends on how much of the brain is dying or what piece of the brain is dying. And so if you have a small piece of the brain dying, you might see small symptoms. If you see a larger piece of the brain, you might see greater symptoms. But it really can come out in a variety of symptoms. So it could be a facial droop. It could be somebody not speaking appropriately or not able to find their words. It could be a weakness, so they might not be moving their arm. They might not be moving their leg. They could be dizzy. They could be off balance. And also it could be just a severe headache. That's a common presentation of the bleeding type stroke. FAST is a great way for family members and people to look for and identify strokes. And so F stands for face. And so you might see somebody's face droop and you can ask them to smile really big, and that's a great way to see if each side of the face looks the same. A for FAST stands for arm, and you can ask somebody to raise their arms and see if one arm begins to droop. You can also have somebody squeeze your fingers on both sides and see if they feel equal and the same. S is for speech, and so someone might have slurred speech or they might have altered speech. They might not be speaking normally. So, and then T is for time. We really need to know when a stroke starts because we have a limited amount of time to really fix people. Our best options are within about 3 hours of having a stroke. So it's not something we want you to wait until the morning and see if it wears off. Fast, and the major point of this is we need to be really fast. You need to come to an emergency department and let us evaluate you as quickly as possible. If you see any symptoms and you're concerned about stroke, please come to the emergency department. Call 911. There are a lot of things that could be strokes that people may not recognize at home. Also, a lot of strokes don't come with a lot of pain, and so patients may not recognize the urgency to be evaluated really soon. We move really fast at Touro Emergency Department, so the worst that can happen if you come and it's not a stroke is that we'll see you, we'll evaluate you quickly, and then we'll get you home safely. But if you wait, we may not be able to fix the stroke, and so that's the worst thing that can happen. So we always want you to come to the ER immediately if you're ever concerned about having a stroke. There's plenty of known risk factors for having a stroke. Some of these are high blood pressure, and this is typically related to how much sodium somebody takes in. And that high blood pressure can cause the blood vessel to burst open, and that's that bleeding type of stroke we talked about. Other risk factors are things that might clog our plumbing. Our blood vessels are our plumbing, just like a kitchen sink might have. And so things that might clog the pipes are things like diabetes, where you have too much sugar and too much fat in our plumbing. Also high cholesterol, especially the bad cholesterol, or the LDL. The people that may have a stroke are typically going to be male. The African American population is more at risk, possibly because of the increased incidence of hypertension. And of course, things like illicit drugs like amphetamines or speedy substances put you at great risk for having a stroke. When you have a stroke, at Turo, we're going to look and see if we can give you a clot buster. This is one of the medicines that we can use to try to help reverse a stroke. And it's important we do this in just within a few hours from the start of the stroke. And so that's why we need people to come to us very quickly. And so we can use TPA, that clot buster. We can also use medicines like aspirin or other antiplatelet agents. If you've had a bleeding type of stroke, though, what we'll try to do is reduce the pressure in the brain. We'll try to control the vital signs, especially like the high blood pressure. Recently, last year, we had a rigorous site review of our stroke program, and we were fortunate enough to receive the Joint Commission Golden Seal of Approval, as well as American Heart Association and American Stroke Association Heart Checkmark. Both of these are incredible symbols of excellence for advanced centers for primary stroke care like we have. And so we're very proud of the care that we give, and we're proud of being recognized for our excellence. Turo's rehab program is known all over the state, and I think it's bar none the best. And ideally, we want you to not have a stroke, but once you've had that stroke, if you have been in that position, rehab is the most important thing. It should start immediately after having the stroke, and it's going to be aligned with the patient's goals to get them back into the community, to get them back in their life.
Our promise to you is to be your hospital for life. Being the CEO at Slidell Memorial Hospital gives me the chance to be passionate about a mission that is focused on the community and not just healthcare delivery. We're providing a culture and an environment where only the best doctors, nurses, and technicians want to work. With the community's investment, they deserve the latest in technology so that they can receive these services right here at home.
Slidell Memorial Hospital, your hospital for life.
Meet Harlan, a hardworking man who suffered most of his adult life with bunions. He shares his story with us on meeting Dr. Reggie, who performed his bunion surgery, and now Harlan is living a happier life. Take a look.
I'm Harlan Gautreaux. Dr. Reggie fixed my bunions on my feet. I had hammer toes. I had all kind of things wrong with my feet. And it has been 25 years that I was suffering for this. It got to a point where my ankles were starting to hurt because it looked like my feet were going one way and my ankles wanted to go straight. And, you know, the boots and stuff, they would wear out because my feet being on an angle and the bunions would poke out the side eventually. So I'd have to constantly get boots and tennis shoes. I would go through tennis shoes and I couldn't wear like cowboy boots or anything with heels. I had to find flat shoes. For 25 years, I've been dealing with this feet problem, you know, and it got progressively worse. You know, when he fixed them, you know, it was like I said, I went to Florida, so my stepson was able to walk on the beach. You know, Drench Quarter Fest was recently, and I probably walked 4 or 5 miles. Actually, I tell everybody I feel like I got 30-year-old feet now. Don't wait till the last minute like I did. Well, don't wait till I get out of hand. Seriously, it's a whole lot easier because I waited until it got so bad that, like I said, there's 4 or 5 things that can go wrong with your foot. I had them all done. I mean, not only did I have no instep, I had an inverted instep. And I think he might have gave me somewhat of an instep now by moving my feet over. But yeah, you don't really want to wait. I'm the oldest of 6, okay? And my brothers and sisters, we always go to Florida for our vacation. And my niece, who is probably like I think 10 now or something, they was asking everybody like the next year we went, like, what do you remember from last year? And she said, Uncle Harlan had ugly feet, you know. So now they fixed.
Packers. Viking. Packers. Viking. Viking.
Red state. Blue state. Vegan.
Carnivore.
We come from different places.
Uptown.
Downtown.
Optimist.
We come to different conclusions.
Half empty.
Half full.
But when we live united, we create real, lasting change in the building blocks of life. The education, income, and health of our communities,
Live.
our families,
United.
even the person next to us.
Live united.
Real change won't happen without you. So give, advocate, volunteer, live united. Sign up at liveunited.org.
Dr. Amenta is a neurosurgeon at Tulane School of Medicine, in affiliation with East Jefferson General Hospital. In this segment, he discusses some of the disorders that he treats at his practice. Take a look.
name is Peter Amenta, and I'm one of the neurosurgeons at East Jefferson General Hospital. I'm a co-director of cranial-based cerebrovascular and endovascular neurosurgery, and I specialize in disorders of the brain and spine. My interests include traumatic brain injury, cranial-based neurosurgery, and vascular neurosurgery, particularly the treatment of aneurysms and malformations of the vessels of the brain. An aneurysm is a weakness in the blood vessels of the brain, usually at points where the blood vessels branch. And over time, the weakness can form what's called an aneurysm, or a bubble on the blood vessel. And there are multiple ways that they can be found. They can either present as a rupture, which is a life-threatening disease, or they can present asymptomatically and incidentally found on the workup of something else. Well, if an aneurysm reaches an incredibly large size, it can cause problems with pressure on different structures in the brain, either seizures or problems with the nerves at the base of the brain. But if it ruptures, patients present with the worst headache of their life and can be very sick, even comatose. And that's a surgical and medical emergency. Usually the patient will have what's called the worst headache of their life, or a thunderclap headache. And a severe headache, they may lose consciousness, they may become nauseous. They'll come to the emergency room, and in the emergency room they'll usually get a CAT scan. And if the aneurysm is ruptured, it will show blood in what's called the subarachnoid space, or the fluid around the brain. The next step is to do an imaging study of the blood vessels, and that can include a CTA, or more commonly what we do is an angiogram, where we enter the body through the groin and then take pictures of the blood vessels in the brain. There are multiple treatment options today for aneurysms. We're able to treat many through the groin by going up through the groin, through the blood vessels, and delivering coils into the aneurysm, or using a combination of stents, balloons, and coils to treat the aneurysm. We also, as neurosurgeons, are capable of opening the head and performing what's called a craniotomy to apply a metal clip to the aneurysm. When an aneurysm ruptures, approximately 50% of the people will not survive. Of those that do survive, a significant number are left with major neurologic deficits, and then a smaller percentage will make a full recovery and return to normal life. So it's a very serious condition. Patients can be left with weakness, they can be left with cognitive disorders, memory disturbances, headaches. Many patients will go on to develop seizures that need to be controlled with medication. If an unruptured aneurysm is treated, patients can go home as soon as the next day if they've had an open craniotomy, usually about a week. But a patient who has had a ruptured aneurysm is usually in the hospital for 2 to 3 weeks recovering before they're able to leave the hospital.
My name's Reggie. Just recently, my wife and I took in her sister's children. Now, we already had 4, so I went from becoming a family man to a man with a bigger family. Now, you can't eat love, so I don't know how I'm gonna feed them tonight. How was that, Rich?
I think I look more like Denzel.
That's cold, man.
Play a role in ending hunger. Visit feedingamerica.org/hunger and find your local food bank.
Up next, Dr. Naresh at Tulane University School of Medicine discusses sexual dysfunction of women and some of the causes and treatments available. Take a look.
Hello, my name is Amber Naresh, and I'm a physician in the Department of Obstetrics and Gynecology at Tulane. Women frequently come to me asking about problems with sex, and they want to know, is there medication available to treat sexual dysfunction? About 10 to 20% of women suffer with sexual dysfunction. This can happen in women of any age, but it's most common in women ages 40 to 60 years old. There are 4 different types of sexual dysfunction. There can be problems with desire, arousal, orgasm, and pain with sex. There are many different causes of sexual dysfunction, including medical and non-medical causes. What can you do if you suspect you may have one of the problems I've described? Well, you can talk with your doctor. It may seem like an embarrassing topic, but it's not embarrassing to us, and your doctor can help. And now back to the question, are there medications available to treat sexual dysfunction? Well, there are medications available to treat some forms of sexual dysfunction in some women. Talk to your doctor to see if one of these medications might be right for you.
Hi, I'm Sean Payton, and I'm here at my neighborhood, Winn-Dixie, where they stock all the fresh and healthy foods we need to live well. The Saints in Winn-Dixie are committed to help the people of Louisiana get fit and stay healthy. Exercising and eating right is easy when you have your whole community to support you, because together we are better. Winn-Dixie and the Saints invite you to join our team. It's easy, it's free, and it's fun. Sign up at livewelllouisiana.com today.
For women suffering from pelvic floor disorders, a variety of treatment options and therapies are available. Dr. Istani, a urogynecologist, explains these options. Take a look.
I am Amenta Istani, female pelvic medicine and reconstructive surgery specialist here at the East Jefferson Hospital. And today I would like to talk to you about pelvic organ prolapse, female pelvic organ prolapse. My practice is devoted to improving the quality of life of women through a multitude of avenues, from expectant management to conservative therapy, all the way to surgical approaches. And the surgical approaches can be from the most, how should we say, invasive to the least invasive, through the latest in minimally invasive surgical techniques featuring robotic technology. Pelvic organ prolapse affects about 50% of all Paris women in the United States. By Paris, I mean people that have had multiple children. So this is very common. Out of that number of people, about 20% will end up having surgical management for this problem. And out of that 20%, I have to say, in the past, many of the surgeries have not had the longevity or consistency that we would have hoped for. And as a result, we're always pushing the boundaries to be able to provide women with approaches that fit the needs of their life. What are these issues? What are the symptoms of pelvic organ prolapse? It could be a sensation of bulge in the genital region, actually seeing parts of their anatomy come out of normal anatomical plane, make them feel less sensual, make them feel less, or make them feel older than they really are. It can lead to pain. It can lead to difficulty passing urine, difficulty passing stool. It can interfere with sexual activity. It can lead to pain of multiple types because it's a very non-specific kind of nagging, pulling issue. This happens as a result of the normal pelvic organs, which have very specific anatomic arrangement, falling out of normal plane, causing a significant amount of morbidity or a lack of quality of life. In order to treat these specific problems, we have very specific approaches. As I said, we can watch it if it's not interfering with the passing of bodily function, or we can take conservative approaches in the form of pessaries, which we use to simply have devices that push the level of prolapse back into plane. It will not cure it, but it is a way to avoid surgery if that is what is best for that specific patient. And then when you come to surgery, sky is the limit. From vaginal approaches where the entire surgery is done through the vagina, a small tube, versus laparotomy where there's an incision made into the abdomen and the abdomen is opened and pelvis is opened, versus minimally invasive techniques. As I say, people always get confused by minimally invasive approaches. What is that? Well, think of a balloon. If you are able to blow up a volume of space, you have created what we say is a lumen. So if you think of the abdomen, you can literally blow it up like a balloon, and that gives you space to operate. And you operate through tubes such as this. where you will place the tube through the inflated abdomen safely and then commence with your operation. When you do a minimally invasive approach, you have to be able to approach the surgery just like you would if you are open. So it takes years of training and years of experience to be able to execute in a confined space, predetermined volume, with very vital structures if you are operating in a minimally invasive approach. People sometimes get confused as to, is this robotic surgery or laparoscopy? I always like to say, in laparoscopy, the physician is manipulating instruments such as this through these tubes. Whereas in robotic surgery, the surgeon is sitting in complete comfort and he has three-dimensional awareness as he is manipulating the robotic arms that are holding the instruments. While both approaches are similar, they are vastly different. And all of these techniques are explained to the patient and how it would meet their needs in thorough consultation.
Any Louisiana citizen who began smoking cigarettes prior to September 1st, 1988, can enroll in the trust. We cover all the cost of medications that are recommended for quitting smoking. The program pays 100% of all approved services. There's no out-of-pocket expense. Anyone who's eligible can quit smoking for free.
Migraines affect millions of men and women in America. Dr. Eric Lanza provides immediate relief with a new sphenocath procedure. Meet his patient Lisa, who discusses her story. Take a look.
My name is Lisa Sister. I'm a patient of Dr. Lanza. I've had migraines probably since my early 20s, so I've had them a long time. Depending on the degree of them, I either can't get out of bed or I'm dizzy, throwing up. I get the aura, the bright lights to where I can't see anything. I've been out before having dinner with friends and had to leave and drive home with polarized sunglasses just to make it home because of the light. So treatment for migraines is a lifesaver for me. I just had the sphenocath procedure. I was probably about a 6'7" prior to, and now I'm about a 2'3". It's pretty easy. You just lay down and, well, first they give you an injection, numb up everything. Then you lay down and then they find their way up, and then after about maybe, the only bad part is you get a little nasty taste and then it goes away after a couple seconds. And then within a few minutes you have relief and feel so much better. If you're nervous, it's not bad. It's over with in seconds. I would definitely give it a try. Anything's better than laying in a bed with a migraine and not being able to go about your life. 5 minutes of your time is worth it. I love Dr. Lanza. Everybody I know will be coming here to take care of their headaches because I'm a walking testimony.
Imagine the world through the eyes of your child, a place full of giants and unreachable places. Now imagine a world if it were designed to fit them, a place where the giants come down to their level, and even the smallest detail is, well, smaller. A place where everything revolves around the kids and their health. Not only did we imagine such a place, we built it with the help of our design team, of course. Children's Hospital New Orleans, caring for every child is our own.
All right, right after this break, we'll have a doctor in the studio who will discuss pain management. We'll be right back.
Doctors New Orleans is underwritten by Blue Cross and Blue Shield of Louisiana, Winn-Dixie, and New Orleans Living Magazine, highlighting the best of our city. You're watching WLAE, New Orleans Public Television. Find us on Facebook and follow us on Twitter.
What if there was a hospital that treated childhood diseases while still allowing kids to have a childhood? It would require thinking on a smaller scale in order to lead to bigger possibilities. It would require doctors and nurses with imaginations as big as those they treat. It would require putting children's lives before all else. It would require a hospital whose singular focus is children. That's Children's Hospital New Orleans, caring for every child as our own.
Good evening, I'm Maria Muro. Welcome back to our show. Tonight our topic is orthopedic conditions and treatment options. My guest is Dr. Christopher Sanchez, an orthopedic surgeon with Paradigm Health System who specializes in orthopedics and sports medicine. He completed medical school at the University of Oklahoma College of Medicine, followed by his residency in orthopedic surgery at Ochsner Clinic Foundation, and we're excited to have him on the show. Thanks, Dr. Sanchez.
Thanks for having me.
I know you're a very busy doctor, so it's always exciting when we have a young, fresh face here in the studio.
Always willing to take time for you.
Love it, love it. Okay, so let's get started. Let's talk about why you chose the field of orthopedics.
In general, as a doctor, you always like to have a problem and be able to fix it. And I found that in the field of orthopedics, that opportunity was presented a lot. We do, as doctors, treat a lot of chronic issues, hypertension, diabetes, and in many of those issues, you're just never able to truly cure the patient. But in orthopedics, I found that there were a lot of times that I'd have a problem, I'd have a solution, and I'd be able to actually help someone in a manner that was very meaningful. So I loved it.
And also you came to New Orleans, you did your residency here, and
I
of
did.
course, good doctor stayed with us, right?
I love New Orleans.
And your children love New Orleans.
They do. I don't know if it's the food or the people or a combination of both, but it's been wonderful down here, so we're going to stay.
Well, for those of you who've met Dr. Sanchez or who have not, he's, besides being a very busy doctor, he's also a very busy dad. So I know that, you're very active with your family life as well. So
Mr. Mom is a very wonderful position. So, hey, Jet, Reese, Sky, I love y'all.
That's very sweet. All right, so let's get started with Paradigm Health System. I know that it's a newer health system that's really making great strides. So tell me about your practice at Paradigm and who is Paradigm?
Yeah, I think with Paradigm, one of the things that's a wonderful thing to recognize is there's been a lot of changes that have gone on in medicine, and we've all seen that probably in the political sphere and whatnot. A lot of changes with legislation in Obamacare, and a lot of reimbursements have become much harder for doctors in private practice to really stay in practice. We're businesses like anything else, so how much money we're bringing in, we have to pay the bills. And reimbursements have gone down, and it's made it difficult for people in individual private practices to survive. So you've seen a lot of big hospitals that have shown up, and the unfortunate part in all of that, I think as doctors we really appreciate the patient and the provider relationship, being able to really have that intimate relationship with our patients to help us make the right decision for the patient. And a lot of that is lost when you get into the big hospital scenes. A lot of it is ran by people in suits. Unfortunately, a lot of those suits have no idea what medicine is, and they make a lot of decisions for us, and I think that takes that out of our hands. With Paradigm, we've been able to kind of integrate multiple specialties. Okay. So we are a multi-specialty practice. We have neurology, interventional pain management, spine, podiatry, orthopedics, sports medicine. So we work as a group in tandem to try to really provide more well-encompassing care for the patient. That does give me the opportunity to really kind of be the one in charge again, the way medicine used to be, where it's more about the doctor providing what's best for the patient. And I think patients really appreciate that. At Paradigm as a whole, we work in Sterling Surgical Hospital. That's kind of our hospital-owned surgical hospital that's located in Slidell. Okay. And what that does is provide us an opportunity to really give patients what they need in a setting that we control. And for that, it's been really wonderful. The patients really seem to feel like it's less of a cookie cutter and more like they're the only patient in the hospital, and I think they really enjoy that.
Absolutely, and I visited Sterling Surgical Hospital. Glad you met that, and it just has it almost feels like you're walking into a hotel and not a hospital, and I love Slidell. So for everybody out there in Slidell, good evening, and definitely go visit with Dr. Sanchez and his team. So now your practice, Dr. Sanchez, orthopedics, I'm so glad that you said, we have to always remember that physicians are also in business. Mm-hmm. And, I've met with so many physicians, and a lot of them struggle in private practice. As you said, with the reimbursements are always being cut, but at the same time, you want to be able to give so much of yourself to your patients. And I know that your team has, definitely does a great job in terms of providing an intimate setting and really open communication. Because I think patients, sometimes we feel a little rushed. We need to remember that we need our time with our doctors, right?
Well, and it's I suppose to that point it becomes more of an assembly line when you get into a bigger kind of a hospital employee setting, where you really have to do the numbers in order to make the money to run that business. And we've been able to harness the ability to get rid of mid-level providers to a certain aspect. When you come into Paradigm Orthopedics and you come into my office, you're not just going to see my nurse, or you're not just going to see my PA and maybe I'll stick my head in. You literally get my ear for a good 20 minutes for each individual patient. And we found that really does, I think, give the patient the opportunity to really let you know what's going on with them. And for sometimes, people come with certain pathologies, and if you'll just spend a little extra time, let them give their symptoms a little bit better, most certainly you can come to a better conclusion as what it will that actually helps them. And to the idea that we do have a lot of specialties, to the aspect of, say I find something that perhaps I can't take care of, but my pain management docs can. It's not something that I give a referral and it goes out into the cloud somewhere and eventually someone calls them. Right. Literally, they're down the hall and I can set up an appointment for them, sometimes even that week. If they need further imaging, I can get it done the next day.
That's
and what that does is gives us an opportunity to care for the patient in a much more expeditious fashion.
Okay, and now geographically, doctor, I know you have a few offices. Tell me about the patients you serve and where they're located.
Well, I treat patients both on the North and the South Shore.
Okay.
I have an office here in Metairie that's right in the Eustis building on Veterans Boulevard. And then I also see patients both in Mandeville, Lacombe, as well as in Slidell.
You're very busy.
Yeah, I'm all over the place. You learn to commute around here, so it's not too bad. Just a little coffee and a little talk radio in the morning, and I do just fine.
I think that's wonderful. And now your patient base, you see mostly adults?
I do. Pediatrics, you'll see a few. I try to stay away from the smaller children. I think those are best served with someone who specializes in pediatrics. For myself, I do see myself in being a community doc to try to help those that are out there. But most certainly, I think when it comes down to pediatrics, it's a very unique niche that you need to kind of probably see a specialist in that. Most certainly, though, I do see just about every age range, all the way from the straight adolescents all the way up into the 80s and 90s. So it's a lot of fun.
Well, fantastic. So now let's get to our topic of orthopedic injuries and orthopedic conditions that you treat. So I just want everybody to know that the phone lines are open. Dr. Sanchez is here to to take your calls. You can call 504-866-3200. You can ask a question. He'll be happy to answer you. Okay, so orthopedic conditions or orthopedic injuries, what are some of the more common ones that you see in your office or in your clinic, doctor?
Well, most certainly, I guess probably an old adage my mom says, don't get old, don't get sick, don't fall. So typically the two of those three ends up being exactly what we see a lot of. People who get old and everything just kind of wears out. So arthritis in general.
Okay.
That's probably one of the most common things that you'll see in an orthopedic office, whether it's degraded knees, hips, shoulders, fingers, toes, you name it, we see all of it. And the other one would be don't fall. So we see a lot of trauma situations where you get in, broken bones, got to be fixed. And so those are probably, whether it's a broken wrist or a broken ankle, we see a lot of that.
Okay. And your practice you practice in general orthopedics, so you cover everything.
I most certainly do. I guess I don't do any spine surgery, so that I leave to the specialist. I think that since you're next to the spinal cord, it's probably best to do that. But for the most part, if you have something that has anything to do with a tendon or a muscle, ligament, or a bone, most certainly I will see that and take care of it as best as I can.
Okay, and arthroscopic surgery, I know that you specialize in that. What exactly is arthroscopic surgery? How is it performed?
Well, for arthroscopic surgery, typically we're just dealing with a joint, whether it's a knee or a shoulder. I'll do ankles and wrists and elbows as well, but what you're doing is you're actually fixing some problem that patient may have, whatever it is, but you're doing so with using a small camera that you can place inside the joint to actually see with a high definition camera what exactly is wrong. And and then through multiple what we call portals, which are just small doorways into the joint, we can use smaller instruments to actually do kind of a microscopic surgery, if you will, but do it under a camera that actually allows us to do what we need to.
Okay, and what are the benefits of arthroscopic surgery?
Most certainly, I guess the return time back to normal.
Okay.
In certain instances, those can be very, very helpful. But then you have like rotator cuff issues where we are repairing tendon or we're repairing ligament with an ACL reconstruction, and there's a lot of rehab that's necessary for those to get to 100%. So it's not necessarily always a quick return. Sometimes it does require a lot of rehab, but most certainly it's a very minimally invasive procedure that you can do. Most of the time we have very small portal sites or the doorway that we use, maybe a couple centimeters, and those could be 2 or 3 that they may actually require.
Okay, well, I'm glad you brought up rotator cuff, torn rotator cuffs. Let's talk about that. I know shoulder injuries are something that you definitely treat a lot. Okay, so tell me about rotator cuff. We have a caller for you.
Sure.
We have Amenta on the line. Good evening. How are you?
I'm good. How are you?
Great. Your question for Dr. Sanchez.
Well, my mom has a few medical issues dealing with her hips, and she's going to actually get a revision coming up next week. I was just wondering if you can go into some details about how difficult that is and, the rehabilitation for that.
A revision for what kind of surgery?
She has she pre-existing had a total hip replacement.
Okay.
And as a kid, she had pins in her hips. So she's had her hip replaced 21 years ago. So she's getting it redone.
Well, that's very understandable. Great question. Revision hip surgery can be a little difficult at times. It's understandable that she had a hip fracture that probably wore her hip out a little quicker than she was expecting it. Certainly, a total hip can last a good 20, 25 years, and it's unfortunate she had to have one as young as she did because she was almost required to have a revision surgery. I would certainly find someone who knows revision surgery and that you can ask the most appropriate questions about that. And in all honesty, that's probably the best advice that I could give you is to ask as many questions as you possibly can. Find out how many they've done, how comfortable they feel this particular surgery. And most of the time in that conversation, you'll get a confidence in your surgeon, which is really what's most important in the patient. You need to understand, 1, what your problem is, and 2, feel confident with the person that's doing this surgery for you. A revision surgery can entail a little bit more rehab. And given the nature of our conversation, I guess I couldn't go into too much more detail outside of that, but it is a little more difficult than a primary hip surgeon or surgery that for a primary osteoarthritic hip, but the outcomes can actually be quite good for her.
Okay, and you had also spoke about the rehabilitation of it. Do you have any good locations that you can do that at, or?
What I would suggest is the one that's easiest for you. And someone that they feel comfortable with as far as dealing with hip revision surgery. Sometimes that involves you having to call your physical therapist before. If she was near the one she had previously worked with, great. I would say just as long as it's a certified physical therapist who understands what will be the restrictions given to her after the surgery is done, that would be the best person for her.
Thank you for your call, Amanda, and definitely if you want to leave your name and phone number, or you can email us. We'll definitely be able to help you and connect you with whether it's a doctor, a physical therapist, or whatever you need. Thank you so much. All right, so doctor, that was a great question. Let's get back to shoulder injuries. So tell me about most common shoulder injuries that you treat.
A lot of the shoulder injuries, I suppose, that we get are really kind of the strain and sprain and the bursitis that come in that are maybe not necessarily operative. A lot of people, I guess the standard story that you'll get that's probably one of the most common problems that you'll have in your shoulder is it gets tough reaching up above your head, trying to grab something, reaching back to mess with your kids somehow. And most of the time that ends up being what we call a shoulder impingement syndrome. This is similar to what we would refer to as a bursitis. Essentially, excellent, we have a nice picture for it, thank you. So for you folks out there, you can see this. This is basically the anatomy of what our shoulder is, and you can see the muscles that come across there. The one known as the acromion, and this is an actual bone that's part of the shoulder girdle that holds your shoulder in place. And what it can do is as your shoulder moves out towards away from your body, which is we call abduction, you can actually have some of these muscles and some of the tissue that's underneath there just rub and cause friction. And what that does is it in turn causes inflammation, and that inflammation can impede your ability to do your normal things. And that's why reaching your hand above your shoulder ends up becoming something quite painful. This can be something that can cause a rotator cuff tear. And that's something that we would really have to do an examination or maybe even get some additional imaging, which would normally be an MRI. There are some non-operative things that we can do, like doing physical therapy, teaching you how to do this, doing some injections or anti-inflammatory medications. Okay. And typically we can help to at least put you in the proper pathway to get you back to better. Most certainly it's something that we deal with on a regular basis. Other shoulder injuries that we deal with, of course, with falls or fractures, whether it's a fractured collarbone or a fractured shoulder, such as the humerus, which would be a proximal humerus. And this is typically something that will happen with the elderly population that'll fall. And a lot of those do get fixed. Some of them are needing shoulder replacement surgeries, which I also do. And, you know, again, that's just something you'd have to get in touch with an orthopedic surgeon in order to have them better define that with an examination.
Okay, and when someone does have a a torn rotator cuff, they feel it. They know they're in a lot of pain, right?
Yeah.
So they need to seek medical attention.
I would put that as such. Yeah.
Okay.
Yeah. No, don't ignore the pain. Don't ignore the pain, please.
Okay.
Pain's a good thing.
And now what about, we hear about frozen shoulder.
Frozen shoulder is a phenomenon where basically the capsule, which is this balloon of fluid that goes around your shoulder joint, becomes very stiff.
Okay.
And that happens for a multitude of reasons. Typically, those who are diabetics happen to see this a lot. And so what we'll see is you cannot move your shoulder and it's very painful for you. This needs to be defined different than, say, a rotator cuff issue, which is one where the muscles in the shoulder themselves no longer work.
Okay.
And only your orthopedic surgeon would be able to do that. Okay. Typically with a frozen shoulder, or what we'd call adhesive capsulitis, what that does is it requires a lot of rehab. We can do a lot of injections. And in certain instances, once those things have failed, we will do something that's called a manipulation under anesthesia. And that can be done. We also have arthroscopic procedures where we can actually go in and really just try to open up the capsule to allow you for a better free range of motion. Sometimes if you have it once, you're prone to getting it again, and it just becomes part of something that you recognize beforehand. And again, that's just something to get a better plan for you once you get with your orthopedic surgeon.
Okay, now we hear this a lot, shoulder dislocation versus a separated shoulder. What exactly is the difference, doctor?
Well, a shoulder dislocation is something that you couldn't ignore. This is where your shoulder will no longer work, and you probably need to get into the emergency room in order to understand.
It happens a lot in sports, right?
It does,
okay.
It does, or in a trauma situation. And really a shoulder separation or shoulder dislocation, and I think this is an excellent slide for you. A shoulder separation is one that happens between your acromion and your clavicle. There's something called your AC joint. I'm sure you've heard it if you've been watching any Saints football. Somebody falls and ends up with an AC separation. And that is not necessarily something that has to be operative or needs attention in general. That's not only something that your orthopedic surgeon and some x-rays would be able to define. Now, a shoulder dislocation is one where you're no longer able to move your arm. And the reason being is because the glenoid, or the ball in the socket, the ball's out of the socket.
Okay.
And we got
Very painful.
Yeah, we need to get the ball back in the socket as quickly as possible. So, and that's not something you want to ignore. Now, there are certain instances with people who have cerebral palsy or post-stroke where we will allow that to stay that way. But for the average individual, we all want to use our arms. Let's get it back in there.
All right, we have a caller for you. We have Larry on the line. Good evening, how are you?
Hey, Larry.
Hey, how you doing, Doc?
Doing well.
I wanted to ask you a question. I just recently had a reverse total shoulder replacement operation in March, and it was a two-part operation. The first part was when they replaced the ball in my shoulder. They replaced it with a titanium ball. And I had a lot of pain after that operation, and it took about 10 years until I finally made the decision to go get it done. And when I seen this doctor, he told me about the total reverse shoulder replacement operation, and I never heard of it. And he told me to go look it up in the internet. And when I did, I was amazed how many videos it had of that. But I learned from the internet that a doctor who invented this type of operation was in Britain, I think they said, and he invented it in 2004. Do you do that type of operation? Because mine was a total success.
Yeah, I do. I do a lot of shoulder operations in general, and I love shoulder replacement surgeries. And I suppose that the shoulder replacement versus the reverse total shoulder, people kind of wonder as to what that definition actually truly is. What we do in a shoulder replacement surgery is we're replacing the ball and the socket. So the ball stays the same and the socket stays the same. We just replace it with either a high molecular, a plastic disc that goes in the socket and a metal ball. With a reverse total shoulder, the purpose for that is when the rotator cuff no longer works, we can no longer expect it to do anything for the shoulder. So when we use a reverse total shoulder, we reverse the ball in the socket. So we put the socket where the head was and the ball where the socket was, and then depend upon your deltoid muscle, which is the big muscle in your shoulder, to use that for motion. It sounds like what you had gone through, if you had had a previous fracture, it's not uncommon to have that. If you just wore it out and your cuff finally went away and you were no longer able to do that, and that's something that you'd have to look at your previous imaging. But yeah, reverse total shoulder has actually been quite a success for us as orthopedic surgeons to give us yet another opportunity, because previous to this, the only thing we had was a total shoulder, and then when the cuff went away, well, then that's just what you had. And now we have another, arrow in our quiver that we can use to really give individuals, and this is probably farther along in the pathology when your shoulder degrades, another chance of success to kind of go back to your life again. And you get great, excellent results with those. I'd say excellent, it's not great, but excellent results with those done appropriately and in the right indication. But I'm glad to hear that your surgery went well.
Thanks for that call, Larry. It was a great question. And doctor, obviously there's many people out there who obviously are in need of your services. So we'll make sure that at the end of the show, we'll give you Dr. Sanchez's contact information as well. All right, we have another caller for you. We have Maxine on the line. Good evening, Maxine. How are you?
Hi, Maxine.
Hello?
Yes, Maxine, your question for Dr. Sanchez? Dr. Sanchez, look this way.
I'm okay the way I am. I have arthritis. So yes, ma'am.
Yes, your question for Dr. Sanchez?
I had a hip.
Sounds like we have.
I had a hip surgery in 2014, and I'm having very bad pain. Can't hardly walk. I'm walking with a walker, and I have a rod in my leg. So what can I do?
Now, did you previously break your hip?
Yes, sir.
And so they fixed it with that? It sounds, Maxine, it sounds like you're suffering from something that's known as post-traumatic arthritis. I guess the easiest way I could explain this is that when we come out of our mama, your bones are meant to be a certain way. And then we go off in a regular life and break those things. And as a result, our bones don't necessarily line up the way that they should. So with your hip, when you broke your hip, you probably misaligned it, whether it was no fault of your own. Obviously, you didn't do it on purpose, but because the way, it's almost like an unbalanced tire. It no longer wears appropriately. And it sounds like you may be suffering from some arthritis that's happening in your hip now. And so that would actually require just a little bit special of a total hip, because we're not only going to be able to do we wouldn't be able to do the hip until we actually take the rod that's out of your leg. And that would be 2 stages. Now, most of the time you could do that probably in one surgery, but I would find somebody that's familiar with that. After that, the total hip success on those that have happened as a result of post-traumatic arthritis still do just as well as those who've had just as a result of primary osteoarthritis, if you will. But it sounds like you're suffering from some pretty severe arthritis in your hip that's happened as a result of having a previous fracture. And that's a common phenomenon that happens, whether it's in your wrist or your shoulder or your hip or your knee. Things just aren't lined up the way that they used to be, and they kind of wear out a little faster, excuse me. But get with your ortho, and I'm sure he'd be more than happy to help.
All right. right. Thank you so much, Dr. Sanchez, and thank you, Maxine. We're running out of time, Doctor. We only have a few minutes, so I want to make sure that we cover, a few more conditions. Obviously, with general orthopedics, we talked about hip replacement, seems something that, of course, of great interest. And now with the knee, do you see? Oh, we have another caller for you. We have Diane on the line. Good evening. Your question for Dr. Sanchez?
Hi, my name is Diana Clem. In 1982, I was in a bad car wreck. A drunk driver drove me off the road into a ditch, and I hit the culvert. The culvert broke my right hip and pelvis, but was it breaking? It busted the main artery in my leg. So I have a drop foot. Well, I guess they put me in an induced coma. And a month and a half later, when I woke up, and the doctor told me at 22 that I'd never walk again, I just kept making my foot go back and forth, making sure for the other month and a half, while being in there, I could use my foot. Because I had a child to raise, and I didn't want to be on the street.
Sure. Okay.
Well, while the doctor was putting the hip replacement in me, it was in a spiral break. I woke up on the operating table asking him, what did you do to my thigh? That's the only good part of my body. Because I broke my wrist falling while waiting tables. But if I would have went to work with a cast, they would have sent me home.
Okay, well, Diane, because we're sorry to cut you off, Diane, because we're going to be running out of time. But what, do you have a question for Doctor?
Now that I am getting older,
okay,
and with the DEA and everything, I've never taken medication but now I can't sleep at night. I can't eat.
Okay.
My immune system's so down that I keep getting infection.
Okay. Well, Diane, this is what I suggest we're going to do, because we're going to have to wrap up the show soon. But if you'd like to leave your phone number with our front desk, they'll be happy to help you, and then we'll definitely be in touch. Okay, sounds like you're in pain, and we can definitely guide you in the right direction, to get some help. So, Dr. Sanchez, obviously, there's a lot of people who are watching the show tonight. It seems like there's a lot of them who've had joint replacement surgery in the past. So, is revision something that you see a lot? Revision surgery?
You do. I mean, typically the life of a total knee or a total hip is 25 to 30 years, depending on how you treat it.
Okay.
Obviously, I tell folks just to try to make sense out of it. It's like putting a new change of tires on somebody. If you drive your car around like a Corvette, it's probably not going to last as long. So you got to be good to yourself. But yeah, revision surgery is becoming something that we do see on a regular basis. Okay. And of course, it's one of those things where you just got to be comfortable with your surgeon, knowing that they feel comfortable doing the surgery itself. It's hard to not find somebody out there who hasn't had something replaced, and it seems like everybody who has a family member, somebody has somebody in their family that's had a total joint of some sort.
Okay.
So it's very predominant, and it's good. I think it speaks well to the success of the orthopedic surgery as a whole.
Absolutely.
and a success to the surgery to give us an opportunity to give people their life back.
Absolutely. And so and again, the success rate is very high when it comes to any type of replacement, knee replacement, shoulder?
If you do it for the right indication, what we found is that if you do the wrong surgery for the wrong patient, obviously the success rate is going to be very low. What I do in my practice is to try to get your, expectations to mirror what reality is. We're not miracle workers, of course. We're putting in fake knees, fake hips, fake shoulders, so it's not going to be the same thing. And if you're doing it for the wrong reasons, then you're always going to be unhappy. So what we try to do is to define that, and the reason you should be doing it is for pain and loss of range of motion. So if you're doing it for those reasons, then I think the success rate on that is absolutely wonderful for people.
Wonderful, doctor. And also because of the aging population, I'm sure that this is something that in orthopedics obviously is going to be more and more in demand.
Absolutely.
With osteoarthritis.
It really is. And with the technology that we've had, we've seen a lot of improvements in the total hips. and total shoulders, any total replacement surgery, just the components that we use are much better, so they're lasting longer. And as long as you're doing the appropriate things afterwards, for those out there who have had total hips and knees, and taking your antibiotics before your colonoscopy or before a dental procedure to keep away from having an infection, things seem to work out real well.
Well, Dr. Sanchez, the show just flew by.
It did.
I know, great questions from everybody, and you were fantastic, Doctor. We want to thank you so much for being here.
Thank you for having me.
And for those of you who wish to contact Dr. Sanchez's office, you may call 985-882-4500, or you can visit his website at paradigmhealth.net. I'm Maria Muro. I want to thank you for tuning in to Doctors New Orleans. And remember, if it's about health, we cover it, and we want to hear from you. Thank you for your calls tonight. We hope you found the show informative, educational, and inspirational. Stay healthy and good night.
Doctors New Orleans is underwritten by Acadian Ambulance Service and New Orleans Living Magazine.
What if there was a hospital that treated childhood diseases while still allowing kids to have a childhood? It would require thinking on a smaller scale in order to lead to bigger possibilities. It would require doctors and nurses with imaginations as big as those they treat. It would require putting children's lives before all else. It would require a hospital whose singular focus is children. That's Children's Hospital New Orleans, caring for every child as our own.
Join us October 13th for the 3rd annual Ringside Roast with special guest Tommy Satanovich of Dragos. We'll be having fun with a star-studded array of roasters and comedians, all for a great cause. The funds will benefit the Education Broadcasting Foundation, which operates WLAE-TV. The roast will be held at the Forum at 3131 Veterans Boulevard in Metairie. Come join us on October 13th. Get your tickets at ringsideroast.com.
Wildfires are an essential part of healthy forests, prairies, and grasslands, helping to keep nature in balance. Periodic fires prevent trees from becoming overcrowded, minimize buildup of flammable leaf matter, return nutrients to the soil, and